This is Alissa.
And this is Chelsea.
Welcome to med-surg Moments, the AMSN podcast.
This podcast is an engaging look at the lives of and surrounding medical surgical nurses.
We're proud med-surg nurses just like you, sharing our stories, insights, and experiences to support you in your nursing journey.
Hey guys, and welcome to another episode of med-surg Moments. Evie and Caroline could not join us, so it's just the two of us today. Alissa, what's new with you?
I am so excited to announce that I received my nursing professional development certification, which just another part of my alphabet
soup. Shout out to you, Alissa. I'm sorry, but that's awesome.
I know. I'm so excited. I don't know what it was. So when COVID started last year, I don't know why I thought that was the perfect time to start moving forward on all my professional development. So in the last year, I was like, I got to get this alphabet soup done. I got to get my med-surg cert. I got to get my nursing professional development cert, and I've got to get this PhD going. I did all three. So the only thing left to complete is the PhD because you just can't get that done in a year. But I've got everything else. So very excited. Got that under my belt. My department so supportive. When I got back to the office and told them that I had passed, maybe 10 minutes later, there was a huge email out to the department. Please join me in congratulating Alissa. It was so sweet. So very excited about that. What's new with you, Chelsea?
I don't know if you guys know this, but I love technology. I don't know if I mentioned this in a previous episode, but I think back in January or February, I gave myself like a little gift. So I have an iPad Pro. So I needed extra screens for, guess what? Trading. I needed some extra screens for trading. So I decided to get an iPad Pro. But now I have my eye set on like an Apple desktop with two screens, and then also keeping my MacBook and my iPad Pro. So I love the iPad Pro. It's awesome. I got this really cool Bluetooth keyboard that kind of like folds. So I love action movies, 8 ladies, early 90s action movies. And this keyboard reminds me of that because it folds up. And I got it for $20 off of Amazon. So I love technology, just chilling with my tech.
For some reason, I can just picture you in your office with 8 screens like you'd see in the movies. Is that your future goal? It's
going to start probably looking that way. Maybe not at that many screens, but I definitely want that like Apple desktop and get 2 monitors for that. So that's something I plan on. I have a savings goal that I'm going to reach by December. And so after that, I'll set some money aside and purchase that Apple desktop.
There you go. I love my Apple desktop. It's amazing.
Oh, I'm so excited. And then I've also been watching lots of basketball. So as you guys know, it's March Madness.
It sure is.
Unfortunately, my alma mater, the University of Virginia, got cut out early. But shout out to Tony Bennett. I know that we'll come back bigger and better and stronger next year. So
does that mean your bracket's been blown?
It's been blown. Yes, it has. And it happened early, but it's all good. I think we have a solid team of talented young men. So looking forward to that. And also shout out to UVA's women's basketball team. I think women's basketball is awesome and they don't get as much support as our men's team. They're out here doing great things too. So
absolutely.
Shout out to both of our basketball teams. So today's topic is complex behavioral health patients. It is something that I really like talking about. I actually, back in 2019 at the last in-person Academy of Medical Surgical Nurses conference, they actually had a lecture about complex behavioral health patients, and it really got my gears turning. What do you guys do with complex behavioral health patients? What protocols and safety nets do you have in place, not only for the safety of the patients, but for the safety of the staff?
That is a great question. It depends on their location in the system. For the med-surg units, having a complex behavioral healthcare patient is so challenging. And I say that because they wouldn't be in that area if they didn't have a medical or surgical need. And so usually there's a lot of tiptoeing around the mental health diagnoses. Unless the patient is aware and speaking freely about it, usually there's just a lot of tiptoeing around it and not outwardly speaking like, wow, your behavior is, escalating, and maybe this is a sign of fill in your behavior and diagnoses. It seems, at least that was my experience when I was there, it felt like you had a mental health patient on your unit with a medical need. And so all you focused on was the medical need. And then we would send them to our inpatient psych unit. And suddenly we can talk all about your mental health issues because that's the focus of the visit. And PS will take care of this dressing change or whatever else the medical need is. So quite a different contrast in that support or resources that we have, right? We always have access to a psychiatry consult and our behavioral emergency response team for those kinds of needs. I imagine we have the same resources in terms of keeping a patient against their will. Essentially, we can blue sheet them or white sheet them. We have all of these options, right? If a doctor feels like the patient needs to stay in the hospital and the patient's trying to leave and they deem that the patient is not safe to make decisions on their own behalf, I believe that's what that means. So we have those kinds of resources, but I think we need to do a better job at helping our nurses and empowering our nurses to discuss the diagnoses with their patients and having an open and honest conversation about, if your diagnosis is anxiety, I don't want to tiptoe around if you're feeling anxious or not anxious. What are the triggers that make you feel anxious? What are the medications that make you feel better or not better? Let's just outwardly talk about, you have a generalized anxiety disorder and you're out of your comfort zone. So I want to help you through this experience so it's not miserable. What can we do about that? Or you're here with borderline personality disorder. What are you doing for that? What are your coping skills? We just need to do a better job of having the open and honest conversation with our patients when they're in a med-surg unit and they have these behavioral issues. That's my experience. What about you, Chelsea? How do you guys handle this in your acute care areas?
Yeah, so unfortunately, we don't have a med-surg psych unit. It is desperately needed. Our psych unit does not have the capacity to take care of psych patients that also have med-surg issues. Another thing that we struggle with is placement for these complex behavioral health patients. So they end up staying at our hospital for a really long time, and it just really puts a strain on staff, but then they also don't get the help that they need. I don't get me wrong, I love our psych team, but psych consults are often lacking. And then we don't get a behavioral plan in place soon enough. It's not until they've been there for a month that we get a behavioral plan in place. But
Wow.
we do try our best to exercise behavioral plans. Sometimes they're a little too generic. And then sometimes our patients have such complex psych issues that they don't work and they don't really serve as a safeguard. And I've dealt with a patient these past few weeks that it's just like nothing worked for them. Not a behavioral health plan, not calling a BERT call, which is behavioral emergency response team. It was just so complicated. And that patient has been there for a very long time. And so it puts a strain on nursing staff. But then also I feel like the patient, we're doing nothing for the patient. So it's really hard. I think a lot of hospitals struggle with complex behavioral health patients. It is not easy to deal with, especially when you're not a psych nurse by trade. You really have to keep those boundaries in place while also taking excellent care of your patient. And that can be so difficult. In previous situations, we've actually rotated patients. So they'll spend 2 weeks on our unit, 2 weeks on another unit, and 2 weeks on another unit. Or we talk about, okay, can we switch floors? So instead of them staying on the 5th floor, can they go on the 6th for a week or 2? So it's incredibly taxing emotionally for nurses. But then you also feel bad because you see that your patient needs intensive psychiatric help and they're not getting that. So it's definitely a challenge. And then you also have to focus on nurse safety. A lot of these patients can and do become violent. So it's definitely not something easy to talk about. And then a lot of the times we don't have a lot of insight into psychiatric disorders like schizophrenia and bipolar disorder. We don't know what to look for. We just say, oh, yeah, this is in their past medical history, but we don't understand people's triggers. Sometimes we don't know how to de-escalate situations. It's just really something that comes with learning that over time. It would be nice to have those resources in place before it happens. So that's definitely something that I would like to work on at my organization.
It's interesting. Our med-surg psych unit, they have the opposite problems as our med-surg inpatient unit because med-surg acute care Their weakness is their psychiatric nursing skills, and our med-surg psych unit, their weakness is their med-surg skills. If only we could just marry it, right? And get everybody's skills up to par, because unfortunately, when the patient's on a med-surg acute care floor, their psychiatric needs are probably not being met. And then when they transfer over to the med-surg psych unit, there's a criteria they have to meet. Their med-surg needs need not be great. But the reason for that is because those psych nurses really do focus on the psychiatric aspect of it. And their med-surg skills are not what I want them to be. Like, that's the nice way to put it. It's what my preference is, that they'd be a little stronger. The good news is we've identified it and we're working on it. One of the other benefits, bonus, I don't know what else you could say about our system, is we actually do have a neuropsychiatric institute connected to our academic medical center. So we do, straight from the emergency room or a transfer off of an acute care unit, can transfer someone to an inpatient psych hospital. But with any psychiatric hospital, placement is challenging because there's very little availability. Unfortunately, mental health is a problem. And so usually the hospital is full. Trying to get placement into that hospital can be quite a challenge because they have a very high census most of the time. What I would love to see is a better, more robust training for both of those units. I want to see my acute care med-surg nurses have the skills and feel empowered to deal with these complex behavioral patients, in addition to dealing with their med-surg needs. And then the same, right, in the med-surg psych unit, I want to see these psych nurses have the empowerment to take ownership over addressing change that comes their way, or feel confident when they get a set of vital signs and somebody's not satting correctly, they know exactly what to do. I want that confidence in both of those units. So while we have the resources, it's not perfect and always room for improvement. I remember being at the bedside. I was charging one night and we had a patient with schizophrenia, and the resources at the time is put them on a 1-to-1 and we'll keep the patient safe. And when I rounded on the 1-to-1, he was standing in the doorway. So I was very happy that he was keeping his exit clear. But the reason he was doing that is because the patient was pacing in front of the window, yelling at his reflection. And that was a level of psychiatric issues that we had never seen before. We were not used to a true psychiatric patient. We were used to anxiety, depression, maybe bipolar, maybe borderline personality disorder that likes to staff split or something like that. But that patient scared me because I was worried about my staff, and my 1-to-1 CNA was at the door, and then across the hallway was a security guard. And I feel like if that's what we have to do to keep the staff safe, that patient was not having his needs met and did not belong on our unit. The other thing that I see a lot in the med-surg units is patients will be admitted for surgery and you're trying to get their home meds started. And my experience with surgeons is they're like, oh, they don't need their antidepressant. They don't need their antipsychotics. They don't need their mood stabilizer. This is just overnight. I don't need to start all of this. They're going to discharge in 2 days. We should not cut somebody off of a mood stabilizer cold turkey, even for 2 days. Please don't do that. And I feel like there's a disconnect even in the physician ordering services of, do they realize the impact they're having by not restarting these home medications? So those are some of the issues that I see here in our facility, where nurses really have to advocate for, please don't stop their antidepressant. Please don't stop their mood stabilizer. We need to get these back going for the patient so that they're not bananas for us in the morning.
I agree. And I definitely appreciate you, Alissa, for advocating for your patients that way. It gets so taxing with these complex behavioral health patients because, like you said, they're not getting the help that they need. And then also staff is becoming worn down from not really getting the resources that they need. I would like to say that I would love to see some sort of program implemented with our new nurses, talking about specifically about complex behavioral health patients and the resources that they can turn to. And I would like to see more robust involvement with psych and behavioral medicine for these patients so that they're not hanging out in our units for a month before they get a behavioral plan in place, or that they're deemed not safe to leave and then their TDO runs out or expires. That's another challenge that we have with a lot of our complex behavioral health patients. Definitely would like to see more resources surrounding that. And I'm hoping our listeners can suggest more resources too. or activate those resources on their units would be awesome.
Yeah. And one thing that I noticed happened a lot on the unit I worked on is if you had a staff member who was really good at those de-escalation techniques, or their personality or their vibe just jived with that type of patient, they were assigned those patients all the time. And then they ultimately were the ones who were getting that fatigue and that burnout, because they're like, oh, you can handle it. You're so good with those kinds of patients. And you're like, I don't want to handle it. Why can't everybody else learn a de-escalation technique or how to just be calm and keep your energy even, or whatever it is that they're doing? And it's not fair, right? It's not fair to those people who have like a good skill set and a good rapport with those staff, because they're almost being punished for being highly skilled. Why can't we get everybody on the same level of skill, provide those resources, and really do what we need to do for the patient and the staff?
I agree. Another frontier that we can tackle this on is in nursing school. So learning those techniques early, because I had learned nothing about complex behavioral health patients in nursing school. I had a psych rotation on a psych unit, but that was about it. So I think learning those safety techniques and advocating for our patients, nursing school would definitely be a great place to start that.
Yeah, I agree with you on that one. When I remember my psych class, I feel like that's an area of nursing that maybe nursing schools have decided that they don't need to put a lot of time in. I do remember my clinicals. They were horrifying because I was in a sexual offender facility, which was just horrifying to me. But the actual class part, I do remember talking about different diagnoses and stuff, but I don't remember discussing like de-escalation techniques and therapeutic rapport and empathy and all the things that you really need to be able to de-escalate a patient, or learning about the crisis cycle, or all those things that are so important to know. I just remember getting a foundation of all these different mental health disorders and the warning from my teacher that as we go through this class, we will be diagnosing ourselves or our family members with all of these things, because that's what happens in nursing school, which I thought was funny because it was super true. Go through class, start diagnosing everyone around you as you go through the mental health disorders. But there wasn't tangible information that I could take and apply when I had a patient with that disorder. I didn't get the skills on how to de-escalate or empathize or pick my words that didn't include calm down or I understand.
So true.
Yeah. So I think going back to nursing school is a great place to start. And then making sure that is followed up with and reinforced at places of employment, right? Places of employment need to decide, what does this look like in your facility? And then reinforce those skills. This is what we want. This is what it looks like. And we're not going to ignore or tiptoe around these patients when they're not in a psych area. We're going to acknowledge and have an open discussion with the patient and make sure that everybody's on the same page, because it's not like the patient doesn't know. It's not a secret.
Exactly. So I agree with all of those things. Definitely starts at the beginning when you're training nurses. And then also having those honest conversations with patients, saying your behavior is not appropriate. And we know that you struggle with this, but we do need to take your meds, or we are going to reinforce this behavioral plan to put a check on your behaviors. Honestly, having those honest, difficult conversations with patients is something that can be challenging to do, but it's necessary. I agree with you, Alissa. I don't think we need to shy away from having those difficult conversations.
So one of the good things that's coming out from AMSN is a resource for this exact patient population. So I know that it's in beta testing right now. Hopefully they're okay if I'm spilling this secret, but it's a program that will be similar to the clinical leadership program. And that will be an amazing resource when it's ready for AMSN members who are interested in bolstering their skill set and their knowledge about these patients. So if you're not getting the resources that you need in your place of employment, at least you'll have somewhere else to go. So something to watch for if you are interested, that should be coming down the pipeline.
Sounds like a wonderful opportunity. Shout out to the Academy of Medical Surgical Nurses for organizing that endeavor.
Absolutely. I think one thing that I am always very, complimentary toward AMSN is their learning needs assessment always seems to be spot on. We have this gap in needs of behavioral health care and education for nurses around it. And they already had this in development. Yeah, I'm really excited for it to come out. And I think it'll be an amazing opportunity for bedside nurses to get that support and knowledge on how to help these patients if they're not getting those resources from their organization. So it'll be a good opportunity.
So Alissa, we're nearing the end of our episode. Let's go ahead and summarize some of what we talked about.
Oh, totally.
So like we said, having open and honest patient conversations to better understand their behavioral health diagnosis and how that might impact their care and also our nursing practice.
Absolutely. And placement for these patients is always a big issue. They don't always get the help they need. So we want to make sure that the bedside nurse is being a good advocate for these patients.
Getting behavioral plan in place as quickly as possible to put a check on some of those negative behaviors.
And making sure that you have that conversation with your patient so that you understand what their triggers may be. That's very important. You can get your resources in place as soon as possible. Just don't be afraid to have that open and honest conversation with your patient about their diagnosis. It's not news to them. This isn't a surprise. And opening that line of dialogue with your patient can actually really help that relationship, that rapport.
And finally, learning as many de-escalation techniques as possible, I think, is super important too. So let's just end with some words of encouragement. I hope you guys continue to have a peaceful and productive week, and that while you're listening to this, you get some words of affirmation and can connect with the material. So be sure to reach out to us on social media and the Academy of Medical Surgical Nurses website. We'd love to hear from you. At us on Twitter. I'm at Parker Chelsea RN. So follow me on Twitter. You can message me, DM me. I'd be more than happy to talk to you, or just have an open ear to go over the content in our podcast.
And just remember, you guys, you're not alone out there. We are here for you. Podcast crew's here for you. You have leadership teams that are behind you. Behind every nurse, there's a loving educator who wants to help you. And we want to be there for you too. So make sure you reach out to us. We want to hear from you. We do look forward to connecting with you on our next episode of med-surg Moments, the AMSN podcast. In the meantime, we want to hear from you. Send us your questions, topic ideas, and feedback via our official med-surg Moments email address. That's amsnpod@amsn.org. That's amsnpod@amsn.org.
We'd also like to remind you to become a member of the Academy of Medical Surgical Nurses or review your membership at www.amsn.org. You receive lots of cool benefits and perks, such as discounted pricing on the annual convention and continuing education.
We encourage you to help us spread the word and subscribe to the med-surg Moments podcast via your smartphone podcast app to receive notifications of future episodes. Please be sure to leave us a review and recommend med-surg Moments wherever you get your podcast to help us reach even more listeners.
We invite you to join the conversation by sharing your ideas and questions on AMSN's Facebook, Instagram, LinkedIn, or Twitter pages. And don't forget to add #MedSurgMoments to your post. Simply enter AMSN on the search field of any of these social media platforms to connect with us.
The content within the med-surg Moments podcast represent the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses. Until next time, I'm Alissa.
I'm Chelsea, and always remember, med-surg Moments is a moment in our lives, a moment in our med-surg careers that makes a huge difference.